presentation of further around the current issues with the TRUS biopsies and if it is actually still needed by urologists to do. And it's more or less it's a review of guidelines around this. Just to recap, for the juniors is the current pathway for suspected male with prostate cancer or elevated PSA. The pathway includes multi-parametric MRI scan followed by prostate biopsies. And in the guidelines, NICE, AUA, and AAU, the TRUS, which is systematic TRUS involving 12 cores. The main concerns has always been in TRUS is all around sepsis, which is 2% as per Bowes. The false negative results, which can go up to 30%, and a significant proportion of histology upgrade if these patients had a follow-up template or on radical prostatectomy samples. The template has always had a greater detection rate, not necessarily all significant prostate cancer, but it has a high detection rate. And this is just because the numbers of cores in template biopsies are higher and it has a greater access to the anterior gland. NICE guidance currently is mentioned as a TRUS biopsy is the main or the first initial method of investigation, but TP biopsies can be considered for the patients who had a previous negative TRUS or inconclusive histology, or in clinical trial can be used to help towards focal therapy in form of mapping TP biopsies or as part of active surveillance protocol, but that varies in the country. And the supported the evidence that would support the use of TRUS first, that's purely come from the PROMISE and the PROTECT studies, but there is no similar data on TP biopsy. European urology, up until early this year, they were mentioning in the guidelines, still in the guidelines, that the TRUS biopsy, systematic TRUS biopsy first, but until January this year, the published in European Urology Platinum Edition that we should all be using template biopsies when possible, and when it's not possible in certain indications, cases, then TRUS biopsy can be used.
Is that template or transperineal?
Concerns. It's all around the TP biopsy carry less infection rate. The mentioned in the paper probably 7 studies, including systematic review and meta-analysis, but they also quoted the paper from BUGI 2020, 73,000 patients with a sepsis rate of 1% in TP biopsies compared to 1.4%. What's happening now? Same urologists who sit in these guidelines panel, involving Tim O'Brien, the president of Bowes, and others, they start this talk, which they call the Trexit Initiative. And Trexit, I will come to it in the slides. It's I think this slide. It's run by a urologist in Southeast London, Cancer Alliance. There's 6 hospitals, and they start to switch the practice from TRUS biopsies to local template biopsies in 2019.
Is it
yeah.
Sally? Yeah. Just checking. Is it template biopsies or transperineal?
Yeah, template biopsies. Yeah. Transperineal template biopsies. The one, the local anesthetic one, that's transperineal.
Yeah. Yes.
Yeah, that's
but I thought template.
Hello?
Template.
It's just local anesthetic TP biopsies. They take 24.
Yes, exactly. Because template means you're using a grid.
Yes.
Template means that you use that grid.
Yes.
Whereas on the TP biopsy, it's freehand.
Yes, that's right.
Okay.
So yeah, in the initial in the review, they highlighted the issues around transrectal biopsies, which I've mentioned earlier, and this is just because of sepsis, mortality rate, antibiotics resistance, and in North America and part of the European countries is actually fluoroquinolones are not licensed. And biopsies, kind of the advantages is the sepsis is less. In some cases, you can also without need of antibiotics. The rate of significant cancer is equivalent, but the axis, that's the standard template biopsies using the grid. Yes, the axis is better. The retention rate initially was talked about as a disadvantage, but then it's mentioned in the studies. The largest one from Canada, the retention rate is as low as 1.6%. But then this is the historical one. The template biopsies using stepper, the grid stepper, which it has to be done under GA. But since then, it's a loss of technique. And yeah, like Mr. Patel said, the freehand technique, which allowed the use of local anesthetic template biopsies. And yes, you will take a less sample, but it still can be done as an outpatient setting with less side effects compared to the standard TRUS biopsy. And yeah, I've shown initiatives which is happening around London. Every single urologist or unit I've spoken to, they're doing that. And currently in the region, I'm aware that Coventry they start using the local anesthetic transperineal biopsies. Currently, Hereford they start using same. I'm not sure about the UHB and Walsall. Probably they're still on the general anesthetic standard template biopsies. The aim of this initiative, I think, the talks is all around making this a standard practice. They want to make a standard practice by end of next year. So most units will, if it's not all, will use the local anesthetic transperineal biopsies instead of the TRUS biopsies.